Blog Talk Radio. Welcome to Medicaid Matters, the only live talk show about the business of Medicaid health care. And now, here's the host of Medicaid Matters, Richard Yadon.
And thank you, Braley, and good afternoon, everyone. Welcome to the July 10th, 2012 edition of Medicaid Matters. I'm Richard Yadon, President and CEO of Managed Medicaid Services and the host of Medicaid Matters, and we'll be here for the next hour talking about topics that are always interesting, sometimes controversial, but always interesting and we hope entertaining as well. Today on the show, we're actually going to be talking about a subject that's probably on everyone's mind, but I don't think gets nearly the amount of attention and discussion that it probably should. And it's not always easy to talk about. I think that's probably true of people who work in healthcare, whether they're administrative or clinically trained people or not. And I think it's very true on people of people who are outside of the healthcare business. The subject is advanced directives, and joining us in just a few minutes to really explore this will be Michael Richards, Executive Director of Government Relations and External Affairs for Gundersen Lutheren Health System. Gundersen has a nationally recognized advanced healthcare planning program that Michael's going to talk to us about, and we're going to learn more about that and just this subject in general. You know, this is a subject that is not maybe necessarily specific to Medicaid, but it's certainly a subject that we all deal with, and a subject that is something that's discussed across all of healthcare. And as we continue to move forward with the Affordable Care Act and whatever version this is going to end up taking and being about and evolving into, I can bet that this is going to be a subject that's going to continually come up and we'll talk about. But before we jump into that, I guess some of the big news in Medicaid right now, which we learned yesterday, is the WellPoint acquisition of Amerigroup. There was an article in Forbes actually this morning that had some information about it. You know, WellPoint, the nation's second largest for-profit insurer, has entered into agreement to purchase Amerigroup for $4.9 billion in cash. That deal will make WellPoint the largest private manager of Medicaid benefits in the country, serving more than 4.5 million Medicaid beneficiaries in 19 states, 13 of which bring significant opportunity to serve dual eligibles qualifying for both Medicaid and Medicare benefits. So big news in Medicaid there, certainly. Two major players coming together. Be interesting to see if this is going to be a trend that we're going to see over the next several years, or just what that means. And you may have an opinion about that, and that's what this show is about. Whether you're listening live on the Blog Talk Radio Network, watching the show at MedicaidTalk.com, or you're catching us on iTunes, you know that you can be a part of today's discussion. Medicaid Matters is a show that's unique in that way. You can directly interact with me or with our guest live with your questions or comments throughout the show today. So if you've got something to say about advanced directives, about how it might be impacting in Medicaid, if you've got something to say about the about the WellPoint or Amerigroup merger, whatever it might be, we'd like to hear from you. The easiest way to do that is to just give us a call. And you can call us at 626-657-2125. And then we'll bring you into the conversation as time permits, and we have the chance to do that. If you can't call, we're also on Twitter. You can tweet a comment or a question to @MedicaidTalk, and we'll get them on the air as time permits. And finally, you can join a live chat that is going on right now on MedicaidTalk.com, and you can be there. You can join us there, and we'll read your comments and your questions on the air again as we have time, and we can fit them into the conversation. We have a lot of people who like to go there and send questions in for our guests. Well, some of you are probably also wondering about my reaction to the recent Supreme Court decision. We may touch on that during the course of our conversation with Michael today, but I think we're going to probably wait until a later show until we have an opportunity to really dig into that. There is still a lot to think about and still a lot to consider with respect to that decision, not the least of which is the elections coming up in November and the impact that that could have on everything going forward. So we'll probably follow those developments and things and keep you informed about that. I'm sure we're going to have some guests over the next several months and through the fall to talk about this subject. So we'll probably just defer a real in-depth conversation on that until another show. All right. Well, advanced directives. That's what we're going to talk about today. Are they a good idea? Do you even have one? Why has this become such a hot topic, not just in Medicaid, but throughout all of the different aspects of health care? And joining me now is Michael Richards. I almost made you a doctor there, Michael. Executive Director of Government Relations and External Affairs at Gundersen Lutheren Health System. Michael has been with Gundersen for 2 years, where he leads the government affairs function, which operates in Wisconsin, Minnesota, Iowa, and Washington, D.C. He also directs the corporate communications department, which has responsibilities for internal and external and web-based communications, the community and preventative care services, which is charged with the wellness programs at businesses and in the community at large. And prior to joining Gundersen, Michael was the director of government affairs for Harley-Davidson, that great healthcare organization as well. So, Michael, thanks for joining us on Medicaid Matters today.
Thank you very muc for having me. I appreciate it.
Good. Well, I know our audience is going to want to know how a Harley guy came to work for a large health system. I remember hearing this story at the Medicaid's Innovation Conference, but why don't you share it with us?
Well, yeah, it's not necessarily a direct link, but it was a stretch to put the two organizations together. But I'd been traveling on the road quite a bit, had a new son, and was forgetting what he looked like when I'd come home from the road, and needed to be dad at home. And then at about the same time, my father got ill and got his care at Gundersen Lutheren. And at that same time, I was looking up his physician online. The job was posted at Gundersen Lutheren. And I thought, as most of my colleagues are running away from healthcare because of the passage of healthcare reform, I kind of put on a firefighter suit and ran right into the fire and thought that with motorcycle policy being staked out for the last 100 years, why not try a hand at healthcare? And it's been truly amazing, the transition, but it's been an eye-opening experience for me, and I love every minute of it.
Well, and if you've probably already learned this, that healthcare can tend to be a very closed industry as far as the opportunity for outsiders to come in and participate in something on a level that you are. I'm not saying it's impossible, but it doesn't happen often. But I am seeing a lot more of that, especially with our company's clients, of an openness to see more people from the outside coming in and bringing in different ideas and different perspectives. Tell us a little bit more than what I read there about your scope of responsibility at Gundersen.
Well, right now I came in initially to run the government affairs function. As you read, we are in Minnesota, Wisconsin, and Iowa, and also Washington, D.C. So we manage the day-to-day operations of the government relations. There's hundreds of bills that come out in every single state, hundreds of regulations that we have to pour through, and not to mention healthcare reform at the federal level and what we have to go through there. We are also one of the founding members of what's called the Healthcare Quality Coalition, which is a kind of a government relations-based, loose-knit coalition that is charged with kind of going and changing the reimbursement for Medicare from a fee-for-service type reimbursement system to more of a value-based reimbursement system. We believe in high quality and low-cost care in Medicare, and that's kind of our integrated systems approach. And we think that there's plenty of money left in Medicare to essentially pay for everything that's needed if it's done in the right way. So, yeah, Healthcare Quality Coalition's taken up a lot of our time. My corporate communications, more on the communications, public relations within the community, internal and external communications. And one that I really like a lot is my community and preventive care services, and that's one group that gets out in the community. They'll go to farm shows and do dermatology screens for skin cancer for the farmers who come in, and that might be the only touch point some of the farmers get during the year. We do smoking cessation programs in the community, some of the weight loss programs, and we're really kind of more of a community benefit than anything, and it really kind of gets us engaged with the community at all different income levels, all different demographics, and all different ages.
Mm-hmm. Well, I would love to have a conversation. It's not our topic today, but what you're talking about is that there's probably enough money in Medicaid right now to make everything work. I don't hear that very often on this show. I don't read about that very often, so that'd be a great conversation for another show, certainly. But how did you get involved in this issue of advance directive?
Well, it kind of started with the government affairs perspective of looking at ways that we can advance some of the physician orders of life-sustaining treatment programs in some of the states, and then when it came into we started to edit a book called Having Your Own Say, Getting the Right Care When It Matters Most, and it was edited by our ethicist, Bernard Hammes. And I started getting into the book of helping them get it published. We had people from AARP. We had folks from some of the healthcare organizations in the Sutter Health, places like that contributed chapters to the book. And so I started reading the book. In fact, I've now read it 4 or 5 times, over the course of editing the book with my department. And it really struck me as an issue that I think more people need to know about. We've heard in the healthcare reform the whole thing about death panels, about trying that the scare tactics, the hyperpartisanship that kind of goes along with it. And we were at kind of ground zero of that. We had pushed for, before I got there, pushed for a piece in healthcare reform that would have reimbursed physicians for having the conversation with their patients about what are the individual and their families' wants and goals as they get older and sicker. And so Gundersen Lutheren, I guess, was center stage for all that hyperpartisanship. And so I wanted to understand the issue a little bit more. And what I really found out is that this is really a personal liberty issue more than anything. It's the individual and their families making decisions for themselves. And I started to look at the community that we live in, and the statistics are unbelievable. And how can Gundersen Lutheren and La Crosse County in Wisconsin on the Mississippi River have such great advanced care planning statistics? 96% of the people who die in our hospitals in La Crosse have an advance directive on file, and 99.4% of the time those advance directives are carried through to the T at the end of life. Patients are getting exactly the type of care that they want. Mm-hmm. So that really kind of pushed me to say, how can we make this more of a national issue, and how can we at Gundersen be a leader even more so, and be more vocal and more of an educational tool for other providers?
Well, I tell you, it's a topic that, as I may have said at the beginning, you hear people kind of talk around the issue. And I don't know that anybody really gets up in the morning and says, hey, it's time for me to confront this and write my advance directive. And the issue is really resonating already. As you were talking there, Michael, with our audience, we had a guest on our live chat who just posted something that says, our family went through this. It is tough. Pre-planning makes it a bit easier. And I don't think there's any question that it certainly does. These end-of-life issues are tough to deal with. They're tough to deal with as an individual, and they're certainly tough to deal with as a family member who's trying to make those decisions. I'm sure that was something, that realization is something that also kind of led you to be a part of this initiative.
Absolutely, and as you look at how our plan was developed, it started in 1986, and our ethicist was just kind of looking at some of the cases we had 3 cases, and the patients didn't know what their parents wanted. And he started scratching his head saying, well, how can we fix that? How can we get these decisions, what their decisions, what they want them to be, how do we get them on paper? And he actually went to the medical residence and looked in the chart on the wall, and it showed when they put everything into our medical record at the time, there was no list on asking that question. Mm-hmm. So he changed all the lists out and make sure that they put it in there. And slowly but surely, we started moving forward to having that conversation. And now, if you're in La Crosse, Wisconsin, you know about the conversation. You know about that, and you are an active participant in your healthcare decisions. Whereas it's not the same across the country, and that's a sad thing because we are all consumers. And, as consumers, especially with healthcare, we should get exactly what we want and what we're paying for. And without advanced directives, advanced care planning, you don't always have that guarantee.
You're absolutely right. Well, we're going to go to a break here for just a minute. We've got some sponsors that we need to hear from. And when we come back, we're going to talk more about this issue. And a really interesting comment that you made, Michael, about it being a personal liberty issue. I don't think a lot of people look at it in that light, and maybe we can take some time and expand on that. We're going to be back in just a few minutes, so we're going to stop for some of these messages. Stay tuned. We're going to have a whole lot more from Michael Richards. And also want to remind you, we have a poll about this subject on the MedicaidTalk.com page as well as the Blog Talk Radio page. So if you have a minute, go on and take the poll. If we get enough people participating, we're going to talk about those results on the show as well. So we'll be back in just a few minutes.
Nurses who want to stay on top of their skills know that the Nursing Informatics Learning Center is the place to go. You'll find articles, tutorials, a blog, e-zine, board-approved CE credits, links, assessments, and consultant services, all available to the global nursing community in one place. If you're a nurse or if your organization employs nurses, you need to visit the Nursing Informatics Learning Center.
By providing access to the care they need and the quality they deserve, Medicaid health plans enhance health outcomes of our nation's underserved. Listen to this letter to a Medicaid health plan that helped save the life of Juan, a 4-year-old with a rare heart disease.
All of your efforts have created a miracle for my son. Even though he was so close to death, you helped. You made a difference. Now he's coming along, little by little, step by step.
Medicaid Health Plans of America, ensuring access to better health care. Learn more at mhpa.org.
Elevating the quality of care with less cost. Today, that's the job of every Medicaid managed care company, but it can't be business as usual. Companies have to coordinate care a different way. The solution is managed Medicaid services. Through our virtual case manager network, our teams of Medicaid assessment specialists, and our new advanced care transitions program, companies can dramatically raise the quality of care without increasing their cost. Visit us today at MedicaidServices.net. Managed Medicaid Services, your best source for innovative care management.
And welcome back to Medicaid Matters. This is the only live and interactive talk show about the business of Medicaid. Hey, wouldn't it be great if your clients or your customers or your employees could listen to Medicaid Matters right from your company website? Well, it'll promote you as a brand leader in the business of Medicaid health care. It'll drive traffic to your site, and it's going to demonstrate your commitment to the innovation in Medicaid health care. If you'd like more information about how you can do this, then email us at info@medicaidservices.net. We'll send you information about just how easy, free, and very effectively you can have your website visitors go to you for the most up-to-date Medicaid healthcare information. If you're on the MedicaidTalk.com page, you can do that right now. Just go ahead and send us your message. Today we're learning about a very successful program, very successful initiative at Gundersen Lutheren Health Systems. With me is Michael Richards, Executive Director of Government Relations and External Affairs. Michael, it might be helpful if you could give our audience some perspective on this issue. I know you said that 96% of the patients who actually pass away at Gundersen Lutheren have an advance directive. And I know from experience in my own family just how challenging these end-of-life issues can be. But in terms of patients each year on a national basis, if you have this number, how big of an issue is this?
This is a huge issue, and I don't think people understand. There's a couple different components to how big of an issue this is. We're the exception to the rule here at Gundersen Lutheren. I mean, and some people will look at this from a monetary standpoint. Some people will look at it from more of a liberty issue, like I talked about, where you come into the hospital and you're unconscious, and everybody looks around, all the family members, and say, "I have no idea what he wants. I have no clue." And what ends up happening is either you give too much or too little care at the end of life. So what we want to have people do is up front, have these conversations. You can start with a power of attorney when they're healthy. You can start with an advance directive when they get older and have a few more chronic illnesses. Or if they're going to die within the next 12 months, then you have a physician order of life-sustaining treatment that's more directed at the issue. But the whole thing starts with a conversation. And what we want to make sure is that the patient gets exactly what they want, not us telling them, but what they want. Some may want more heroic care. Some may want to be just to have palliative care and live the remainder of their life in comfort around their family. Mm-hmm. It's all up to the individual customer. But then there's the other side of the monetary side, which I'll throw some statistics out for you here. At Gundersen Lutheren, during your last 2 years of life, the average patient will spend 13.5 days in the hospital for a total cost of care for the patient for the last 2 years of life at $18,359. Now, if you go to if you go to New York University Medical Center, you will spend 54.3 days in the hospital with a cost of $65,660. That's a pretty big difference. And when you look at for this audience, the Medicaid side of it, you have 9.5 million people who are dual eligibles. You have more baby boomers who are getting into that are spending down to get into Medicare and Medicaid. That's a lot of time that's spent in the hospital. That's a lot of time. That's a lot of money that's spent. And a lot of times it's because the patients aren't getting exactly the care they want, because the medical record doesn't show what their wishes are. At Gundersen, being efficient with our medical record, our physicians know to look for it. We've had the conversations. We know, and we keep the families in the loop on what's happening throughout the process. That's why there's less hospital stays. That's why there's a lower cost. Mm-hmm. And it really wasn't about the cost to begin with. It was just basically about getting the patients the right care when it mattered most. So that's kind of the two-sided perspective that you have. You have both, getting the care you want, and then the secondary issue, which came as a result of that, is the financial issue.
Mm-hmm. Yeah, it is an interesting issue as you look at both sides of it. I don't know if you saw this, Michael, or not, but there was an article in this Saturday's Wall Street Journal. It's called "The Crushing Cost of Care." And it was really interesting. I thought it was very appropriate that the article came out just in time for our show here. One of the things I read in that article that I thought was pretty interesting, and it certainly, I think, illustrates that Gundersen is the exception to what's going on. The article states that many factors can make a patient's care expensive. Doctors are trained to push the boundaries of what is possible. Families want to exhaust their options. Patients themselves rarely make plans for dying, the period that typically costs the most. It'd be if we have a physician or two that's listening today, it'd be interesting to get your perspective on that. But that's really what we're talking about here. It's that that end of life issue, and people that don't plan for it. It just creates all kinds of problems, doesn't it?
It does, and I think what happens is when there is a lack of understanding of the patient's wishes, when the patient is able to kind of talk with their family members, with the best medical advice possible, studies show that they're going to want less care. It's their own personal decision, but they'll want less care. They might have had cancer. They might have gone through all the treatments. The cancer may have come back, and they've said, you know what, I'm not going to do this again, and I want to die comfortably, and I want to be surrounded by my family, and that's kind of it's all the patient's decision at the end of the day. So what that article points out is that there is a problem in America, and it's a communication problem. We have a medical record. We've had a medical record for 20 years, where our medical record is throughout our 19 county service territory with many regional clinics. And if you die or if you get very sick in one of our outlying regional areas, you've had your advanced care plan put in place. That's going to show up at our hospitals here in La Crosse. And our doctors know, because it's ingrained in them as soon as they step in the door here. They know to look for that care. They know to look for exactly what the patient wants. And then we work with the families on keeping them in the loop throughout the entire process as the last 2 years of life progress.
Do you think this is something that has become a more prevalent issue here in the last 20 years because people are living longer? I mean, it just strikes me that these kinds of conversations did not go on 25, 30, 40 years ago.
Absolutely, and our book kind of goes through that. Our book kind of talks about all the best practices that are out there. Back at the turn of the century, turn of the 20th century, it's been one of those things where you started finding out how to prolong people's lives. You started saving them, but you didn't think about what it's going to, when you kind of expand or extend life, what that's going to mean to the system. And all of a sudden now you have people living longer, and we've done all the heroic care in the past of keeping people to live longer, but we've never done anything on the back end of, how do we deal with patients when there's no more treatment options available. They're older, and they have multiple chronic conditions. We've kept them alive for many, many years, longer than they had been, 50, 60 years prior, but we don't have a plan of how to move forward from there. And how do we get them to get the care that they want when all other options are exhausted? And I think it's a real problem. I think it's something that we need to face moving forward. And it shouldn't be about the dollars and cents. It should be about the patient getting the care that they want, and ultimately when that happens, it's dollars and cents, because the patients will want less.
Medicare patients rack up disproportionate costs in the final year of life. In 2009, 6.6 of the people who received hospital care died. Those 1.6 million people accounted for 23.3% of total hospital expenditures, the Wall Street Journal analysis shows. So, we don't want it to be a dollars and cents issue. I think the statement you made about it being a personal liberty issue strikes a chord with almost all of us. But at some point in time, it does become a dollars and cents issue. What kind of expenditures are we looking at in the care of someone whose life is being prolonged, but really never improves in the quality of their life, and they end up passing away, and nobody knew what their wishes were? I mean, can you maybe give us a comparison between what that looks like compared to someone who does have a directive?
Well, there's the dollars and cents on the personal side with and also the emotional toll that it plays. So if you don't have an advanced directive, you don't have, or maybe you do, and there's a lot of people that have advanced care plans that are out there, but the health systems that they're in don't have the capacity to either look for them or don't have a very good communication system or a culture of addressing those issues as we do here at Gundersen Lutheren. So there's that financial toll that all of a sudden your families are racked with, huge medical bills and the uncertainty of, did we do the right thing for mom and dad, and it gets to be a pretty big issue. But on the financial side, I mean, I kind of talked about the chart. We're from Gundersen Lutheren spending in the last 2 years of life $18,000 per patient, to Miami and New York spending $63,000 and $65,000 per patient. That's a pretty big gap. And our folks
Is that average?
aren't healthy. Aren't healthier or anything. I mean, we in Wisconsin, we are more obese, we smoke more, and we drink more. And so it's not a demographic issue. It's a systems issue, is what it is.
Right. So the 18,000 that you were talking about there at Gundersen, that's an average of all patients, whether they have the directive or not, correct?
Well, right, and as we've addressed before, 96% of those people have an advanced care plan, and so it's those two numbers are correlated.
Right.
For the people in the last 2 years, I mean, we make an effort to make sure that they understand that there are tools available to them, and we'll sit down with them. We'll have the clergy in our community sit down with them. We'll have social workers sit down with them. We have people who are trained to have these conversations. So it doesn't have to come necessarily from a physician. They can come from people that they trust in the community. And so that's why we see numbers and hospitalizations so much lower in La Crosse County than in Miami and New York and LA.
One of the guests in our chat room, Michael, is asking, at what age does Gundersen suggest an advanced directive be put in place?
Well, we think you should start the conversation early, and like I said, there's 3 points to this. The first is, you should have a power of attorney for health care right off the bat. Once you start having more chronic illnesses as you start to age, and really dependent upon when those factors start, but it's never hurts to start early. Then you start to have an advanced care plan, advanced directive. What from a broad standpoint are you willing to do and not willing to do? And then once as you get towards the last 2 years of life or the last year of life are in place, and pretty much when the end is going to be near, that's when you sit down and really have a POLST form, physician order of life-sustaining treatment. What is it that you really want to have based on your individual diagnosis? And then you sit down and you have all those 3 things in place. So from my perspective, it doesn't hurt to start early. You can always change your plan. You go in for your annual wellness exam, you can start talking about and changing your plan. The big thing is starting that conversation. No one wants to talk about death. No one wants to talk about the care they're going to want at the end of life. But it's so important, not only for themselves to get what they want, but for their family to know, and their family not to have to make that decision and live with it without knowing what your wishes were.
Yeah, very important. I started my career, many years ago in the life insurance business, and it was hard to have those conversations as well. So I can certainly appreciate it. I can certainly appreciate it. Well, we're going to take another short break here. I think everyone is enjoying it, judging from the number of viewers that we have today, as well as people on the chat line. I know this is an issue that is resonating, and everyone is enjoying the conversation. So we're going to take a break here for just a few minutes, and then when we come back, we're going to talk a little bit about the Medicaid aspect of this issue. We are the Medicaid Matters talk show, so we want to get around to that. But I think everyone can see it's an issue that spans a lot more than just Medicaid. But we'll get to that and be back in just a minute.
Medicaid Matters is now booking guests. Who are we looking for? We're looking for people who can bring a fresh and unique perspective to the business of Medicaid health care. Do you have an idea that is unique, innovative, maybe even controversial? We want to hear from you. Go to MedicaidTalk.com, complete our guest questionnaire, and we'll be in touch with you to schedule an upcoming episode. Be a part of Medicaid Talk.
The Medicaid landscape is changing fast, and that means challenges, but it also means opportunity. Opportunity for you. And that's why you need to visit MedicaidJobs.net. MedicaidJobs.net is the place to showcase your talent to Medicaid companies, search for jobs, research the latest career trends, and register for the free Career Optimizer service. Don't wait. Go to MedicaidJobs.net today.
You're listening to Medicaid Matters on the blogtalkradio.com network.
Well, let me tell you about a way that you can bring your company's message to over 6,000 Medicaid professionals. And that's by being a sponsor of the Medicaid Matters Talk Show. Info@MedicaidServices.net is where you can email to get some more information about joining the Medicaid Talk community. We hope to hear from you. Now, next month, Medicaid Matters will be broadcasting live from the Medicaid Enterprise Systems Conference in Boston, Massachusetts. If you're involved in MMIS in any way, you know this has been known for many years as the MMIS conference. But it's changed, and it is the conference that brings together thought leaders from both the public and private sectors to share ideas, to talk about information, all related to Medicaid systems and initiatives. If you go to MedicaidTalk.com, you'll see a link to that there, and you can get all the information about the event. So let's continue our conversation now with Michael Richards about advanced directives. And Michael, I want to turn the conversation now to Medicaid and ask you if you've found any particular or any issue in this subject matter, particular or specific to the Medicaid population.
Yeah, and actually we have, and we went through an exercise probably about a year ago to look kind of at our demographic here in our community when the census had come out. We wanted to make sure we understood what our general population looked like. And in our area, we're an aging population, heavily aging population, and we don't have many younger generations popping up as to the level that we would like them to be. But so we're looking at for the next 10 years, what is it going to look like when the baby boomers start coming in? And we started thinking about also what the per capita income was. And we noticed that we have a lot of people who are on the borderline between Medicare and being dual eligible. And as we've seen, a lot of people are now spending down to get into the nursing homes through their Medicaid programs. And so it really becomes an issue for us. 50% of our general population right now is on a government pay, whether it's through Medicare or Medicaid. And when our reimbursement is so low for Medicare in our service territory, compared to other people, we're starting to look at ways that we can not only streamline the care that we provide to these patients, but also provide them some of the highest quality. We have a long history with Medicare of being one of the lowest utilizers of health care in the country, and one of the least expensive and highest quality. But how can we take that to Medicaid? And a lot of these patients that we're seeing now are dual eligibles. And so when you look at the dual eligible population, 60% of them have chronic conditions. How can we reach out to them through our advanced care program? And how do we get them engaged in this process on the front end so that they can get the care that they want, but also then we can minimize the amount of excessive services that we would have to provide if we didn't know what they wanted. So it's a pretty big deal, and I can't quantify an actual number on what that would look like, but if our history shows, I mean, we're going to be very efficient in how we provide care to these patients.
Well, let's explore that for just a minute, because I know this would be a topic of particular interest to, of course, our audience, but how do you reach out to, or how are you reaching out to the Medicaid population to have a conversation like this? Because it's, oftentimes the members of that population, they're in the system, they're out of the system, they're in the system, they're out of the system, and I think your chart service that you described, or chart program that you described, is an excellent way to do this. But this is a population that moves around a lot. So tell us a little bit about how you're trying to reach them in terms of this issue.
Well, what's interesting is not only at Gundersen Lutheren, but also across the street, about 6 blocks from here, our competitor's hospital as well. They run the same program that we do. It's a very community-based program that we run here, and a lot of that Medicaid population will go between the two health systems. And we've been able to share, with electronic medical record, and also with just our collaboration over the years, have been able to share information on them. But really goes back to when they come into our office for a wellness exam, that we have our medical chart, and we can go through and say, here are your issues. Have you considered an advanced care plan? And it's really more of us being the proactive person. And it really doesn't matter who you are. You could be private pay, you could be self-pay, you could be government pay. We don't treat our patients any differently no matter who you are. In fact, our physicians don't even want to know who their payer are because they don't want it to even come into their mind. But they will go through the same exact thing for everybody and say, these are the issues that you have. And then we make sure that we notate everything and make sure that everybody gets the resources that they need for advanced care planning. So, we go into nursing homes. We have events in the community where people can come in, and really we make ourselves as accessible as possible.
And I think our listeners recognize that seems to be a key for many of the Medicaid health plans as well. There is a much greater push to to connect and synchronize the activities of a lot of community-based resources to reach the members of the Medicaid health plan or the Medicaid population.
Go ahead. I was just going to say one thing that we have at Gundersen Lutheren, which is a kind of another flagship program that we have, is our care coordination program. We take the sickest 1 to 2% of our patients, who account for well over 50% of all the cost of care at our facility, and no matter what their payer mix is, a lot of them happen to be Medicaid, Medicare patients, but